Hi, everybody. For this week's clinical conference, I saw a patient, PN, who was a 19-year-old male with a past medical history of cyclic vomiting syndrome and a past psychiatric history of major depressive disorder, anxiety, and two suicide attempts, which subsequently resulted in a psychiatric hospitalization. And he presented to the MOT emergency room for persistent nausea, vomiting, and epigastric abdominal pain. The patient is experiencing some significant anxiety, which has contributed to his psychosocial distress or psychological distress. He was becoming very tearful during our interview, and we discussed ways that he's coping with all of the stressors that he's going through. He says that he copes with his stress by crying frequently and vaping marijuana. He's been vaping marijuana 2 to 3 times per day to mitigate his anxiety and depressed mood. And he just recently discontinued his marijuana use 4 days ago during his current hospitalization. So he vapes pretty significantly on a very daily basis and goes through 2 to 3 cartridges of the marijuana vaping form, the liquid form, in in a week. And he's been doing this for a year and a half. So he was originally advised to discontinue his marijuana use back in November of 2021, but and he did. He stopped smoking the bud form, but he was not aware that the vaping form was also a part of that recommendation. And just to talk about a little bit about the psychosocial aspect of his stress, he is an African American male and he was adopted by a white family, so he's experiencing some like identity stressors about, is he white, is he black, and has a lot of stress about that as well. Also, he's a senior in high school and he's dual enrolled in a college setting where he can also get college credits before he graduates from high school. And that has also been stressful because the teacher who is over the dual enrollment program has been treating him poorly and has not been kind of been like out to get him. And also he also works part-time at Myers as a cashier. So upon psychiatric review of systems, he's endorsing symptoms of anxiety and he rates his anxiety as a 5 out of 10. He described his mood as good over the past few weeks and currently, and he endorses sleeping well and has a good appetite and is able to complete his ADLs regularly, such as showering and brushing his teeth. He denies any suicidal ideations and rates his mood as a 7 out of 10 over the past 2 weeks and 5 out of 10 currently. He denies any auditory or visual hallucinations, delusions, or symptoms of mania. So for his diagnosis, Access 1 is depression, anxiety, and marijuana substance use. Access 2 is deferred. Access 3 is cannabis hyperemesis and abdominal pain. Access 4 is being bullied at school and being adopted. And Access 5 is 60. So for research, I found an article that talks about cannabis hyperemesis and the treatment for the syndrome. And it says that cannabis hyperemesis syndrome is characterized by symptoms of cyclic abdominal pain, nausea, and vomiting in patients with frequent cannabis use over extended periods of time. A unique hallmark of CHS is temporary relief of symptoms with hot showers or baths, which often lead to compulsive bathing and impractical solutions of management. It is often refractory to treatment with common antiemetics and the transient receptor potential velinoid 1 or TRPV1 receptor family may play a central role in the pathogenesis of CHS because capsaicin is known to alleviate the is known to activate the TRP1 receptor. And this study looked at 13 different patients in a hospital setting, and it concluded that capsaicin was associated with improvement in symptoms of CHS after other treatments had failed. All right, thank you. Let me know if you have any questions.